So what is TEAM? TEAM is a 5-year episode-based payment model that's going to be running from January 2026 to December 2030. It is mandatory for acute care, safety net, rural, Medicare dependent, sole community, and essential access community hospitals based in about 25% of all core-based statistical areas. There are 5 procedure types included, and those are lower extremity joint replacements. So those are your knees, hips, and ankles. Surgical hip and femur fracture repairs, spinal fusions, CABG, and major bowel procedures. And just in case not everyone here is aware, there are actually 30 hospitals within the state of Louisiana that have been selected for TEAM. We have them listed here, but again, you'll have access to these slides afterwards so that you can reference. So every year, CMS is going to review and conduct reconciliation 6 months after the end of each previous performance year. So what happens is CMS determines a target price for each procedure-based episode per hospital. That's based on things like location and historical cost data. If a TEAM participant spends less than their target price, they will receive a financial incentive. If they spend more, they'll owe a repayment to CMS. So a hospital's overall performance under TEAM is really based on that comparing spending from their actual costs versus their target costs, but also on performance on quality measures on things like hospital readmissions, patient safety, and PROMs. Now, an example scenario under TEAM might look a little something like this. So, patient at a TEAM hospital undergoes one of the included procedures, of which CMS has determined the target cost to be $23,500. So, patient ends up needing to stay 3 nights in the hospital, and on that 3rd day, social work comes in and determines that home is not a safe discharge plan because they don't have a care partner identified. So as a result, that patient is discharged to SNF. A little further down the line, after about 10 days in SNF, that patient goes home and ends up having to utilize around $6,500 worth of post-acute and home health services, bringing the total cost of that episode for that patient to $24,700. So in this scenario, that participating hospital will owe $1,200 for that specific episode. Now, under TEAM, participant performance on quality measures will impact their what's called the composite quality score, or CQS, which directly affects the payment reconciliation at the end of each performance year. It effectively ties quality performance to reimbursement. And so how that works is when that CQS is constructed, based on the quality measures listed on this slide, the hospital's reconciliation amount is then adjusted based on that performance score. In the first year, the measures are focused around readmissions, PROMs, and patient safety. And then in years 2 through 5, they're more focused around things like falls resulting in injury, post-op respiratory failure, and the rate of death after procedure within 30 days of that procedure. There's also been an additional information transfer aspect proposed to be included in this model very recently. Just last month, actually, this was proposed. And what this is a one-time 9-question survey that is to be administered between 2 to 7 days after surgery. And the goal of this short survey is to collect patient feedback around the clarity of the recovery information they receive after discharge. So the CMS has proposed to include this as an additional quality measure in years 3 through 5 for TEAM, but it's actually already included as part of the hospital outpatient quality reporting program, where, as we mentioned previously, it will become mandatory in 2027 after 1 year of voluntary reporting in 2026. Now, the team rollout is being done in sort of a track system. So all participating hospitals will begin on track 1 unless they choose to begin on track 3. Track 1 is the only track in which there's no downside risk, and this track also has moderate upside potential. Track 2 is only an option for certain hospitals, so safety net hospitals, hospitals in rural areas, or Medicare dependent sole community or essential access community hospitals. So it's not available for everyone, but this track has minimal upside and downside risk, and is only available to follow from years 2 through 5. So even if an eligible hospital were to choose that track, they would still likely be following track 1 for that first year. And finally, on track 3, all participants are eligible to start on this track. There's higher upside potential, but also a higher downside risk. And a few just last additional elements of team that I just want to mention. So team participants will also be required as part of the hospital discharge planning process to provide patients with a referral to a supplier of primary care services on or before their discharge from the team eligible hospitalization or procedure. Previously, CMS had requested that team participants submit health equity plans, collect and report demographic data, and screen for health-related social needs, but those have recently been proposed to be removed from the requirements. So if things are ever changing, we will continue to stay on top of the proposals and the final rules, and update our information accordingly. So similarly to our top 3 challenges for ProPM, we've identified what we anticipate being the top 3 challenges for team based on what we've seen with ProPM and what we know about our clients, and also what some of our clients that are included in this mandate have expressed to us. So the first main challenge that we've identified is the lack of visibility into episode cost data. It's hard to figure out where a hospital might be struggling, and we find that quality folks really have a tough time wrapping their arms around that and finding where the opportunities to reduce costs might be. And so while team hasn't started yet, what we've heard here from our conversations with those clients that have experience with bundled payments like CJR, one of the most important drivers of success there has been really making sure that they have the right infrastructure in place to validate their cost data and be able to report back into CMS as well as registries or other insurers. Now, what's more is that the ability to have a reliable accounting analytics platform can really offer some valuable visibility into the sort of more granular details of per procedure costs. Of course, that's not always realistic for every hospital. It's just not something that everyone might have available to them. And so when that's the case, the use of a digital tool that can offer real-time insights into things like patient satisfaction, aggregated data around discharge location or post-op complication, that can really help support these cost containment initiatives, even when a hospital or a quality team might not have that granular level of visibility into their specific cost data. The second challenge that we see relating to team down the line, and that honestly we already see in a bunch of different contexts, is care plan variation. The lack of standardization in patient care plans, I think we all know, can really cause a whole list of problems, but through the lens of team are very likely to cause overinflation of cost. So despite the fact that team is not currently in action, this is actually something that we very frequently help address with our clients for a multitude of other reasons. And we found that is that developing and using those standardized evidence-based care pathways can really help ensure consistency and quality in patient recovery. And it also helps reduce unnecessary variation, which can cause higher costs. Of course, implementing digital solutions can be really valuable here, but it's especially important to introduce a solution that is able to support global standardization with certain levels of personalization where it's needed. Because while maintaining standardization where possible can be key for cost containment, we also all know that not every patient is the same, right? Every patient is different, and we do need to make sure that we account for that. And then the ability to have access to and leverage clinical insights and data to be able to make refinements and changes to care pathways with as quick a turnaround time as possible is also super important. Really what you want is the ability to have access to patient outcomes in order to really drive care redesign and also to ensure that your program is continuing to evolve where it matters most and where it's going to have the most impact. And then the last challenge that we've identified will just be a lack of patient compliance to their recovery plans. Again, this is not an uncommon thing that I'm sure a lot of you can relate to. And obviously, again, this also poses a whole list of problems, but within the context of this mandate, patient noncompliance is a big driver of higher costs. So it's really important to ensure that care plans patients are expected to follow are clear and accessible because, mainly as patients, when we understand what we're supposed to be doing, we're much more likely to actually do it. Digitizing the recovery process can really help here. The vast majority of patients are, at this point, used to some form of technology and even really come to expect it now sometimes, whether that's in the form of an EHR, app-based health portal, or some other type of digital program to track their progress. Tracking their progress, filling out forms, and submitting data points is not something that's unfamiliar to many patients. And then, of course, establishing effective communication between your teams and your patients helps immensely when it comes to patient compliance. We really find that when patients feel like they can get answers to their questions, doesn't even really matter so much how they're getting those answers, they're doing the right thing, and we find that really bolsters compliance.